Good morning, everyone. Welcome to Grand Rounds. Before I introduce the speaker, I would like to thank a family that has made this Grand Rounds possible. Miss Elizabeth Tobin and Gregory Kopczynski. Miss Tobin is sitting right here. Gregory is a heart transplant patient who I've cared for many years. In doing so, I got to know Elizabeth really well, and she's been the number one reason for his recovery. Along the journey, she's become very passionate about heart failure and treatments for heart failure, and has been really involved in the section as a whole. So thank you, Elizabeth, for that. So it's my great honor to welcome Dr. Mariel Jessup to Yale for Cardiology Grand Rounds. Dr. Jessup is the Chief Science and Medical Officer of the American Heart Association. She's responsible for leading the association's science enterprise, including our the science and medical strategy and key strategic science relationships. She was previously the president of the AHA. So many might not know this about Dr. Jessup, but she spent her formative years right here. She went to high school in Hamden, right next door, going to school close to Yale. Apparently she felt that you either go to an Ivy League college or you don't go to college at all. At that time, Yale, I don't believe, was taking women, so she ended up going to Penn. She stayed in Philadelphia for her medical and cardiology training. It was there that she fell in love with heart failure and created and led one of the premier advanced heart failure and transplant programs in the world. Dr. Jessup, I think, is best known for her mentorship and for playing it forward. She has been instrumental in giving back so much to the community of cardiologists that there are few who have not been impacted by her. We are indeed honored to have her come back here to her hometown to give Cardiology Grand Rounds. Thank you, Dr. Jessup.
Well, thank you, Tariq, and I really appreciate your kind introduction, and I really am enjoying being here after living here and, in fact, having so many formative years. I haven't really been back to New Haven since I left for college many moons ago. So it's really fun. We had an unbelievably good dinner that wasn't completely heart healthy last night. And it was really good to get a sense of the community, the academic community, and the cardiology community. So I'm going to talk about clinical practice guidelines, which may make you want to roll your eyes. And it's important to note that I have no disclosures from industry, but as you heard, I work for the American Heart Association, and every once in a while, kind of some subtle endorsement of the American Heart Association may creep out in my comments. So I mentioned that back in the days when Yale wasn't accepting women, I started my career, and since then I've participated in 5 heart failure guidelines, including the ESC guidelines, 1 clinical pathway, 1 data and standards committee, countless reviews, 3 training statements, 1 lifelong learning statement, and endless lectures about heart failure. And that's been great for me and great for my career. And I was hoping that I could come and say it's been great for heart failure. So over the years, we've defined heart failure. When I first started, HFpEF wasn't a recognized entity. For those of you who don't know, it first started to show up in the literature in about 1987. I know some of you weren't born then, but we really didn't understand HFpEF at all. We just thought somebody had made a mistake somewhere along the line. And so this was the description we used in 2003 to show sort of the 2 kinds of heart failure. And since then, we have a heart failure with mid-range ejection fraction, just because we needed something else to argue about. Also, as part of the guidelines, we came up with the stages of heart failure. We thought that that was really an advance. We wanted to convey, very similar to what they did in cancer, that there were signs and there were conditions that made you high risk for heart failure, which was stage A, and so on, and that you really couldn't go backwards once you became a stage C or stage D, unless, of course, you had a heart transplant, then you get to start over again. And as you all know, guidelines nowadays have algorithms, and we were so proud and worked so hard on the most recent American guidelines on this algorithm about stage C heart failure with reduced ejection fraction. We thought this was really crystal clear, and I can't even begin to tell you how many people thought this was really misleading and confusing and not helpful at all, because it didn't really sort of prioritize what you should consider first, MRAs or ARNI or hydralazine nitrates. Nevertheless, this has become sort of the standard in guidelines. And of course, there's just the endless number of big clinical trials that make up the foundation of our recommendations. Again, I've been really privileged to be able to watch this as it happens. So first with ACE inhibitors, and this is just the mortality benefit using ACE and HFrEF. All of you know this because it's really old data. And likewise, beta blockers. I still was learning cardiology when we were told never use a beta blocker in somebody with heart failure, you'll kill them. My mentor, Carl Weber at Penn, got this insane idea when I was a fellow that he had read the original 1975 report from the Swedes that beta blockers might help in some patients with HFrEF. And he decided in one of our patients who had sort of an unexplained tachycardia that we would give him beta blockers. I never was so anxious in my whole life. Not only did it help this young man at the time, we gave it to 2 more patients, and those 3 patients who had very low ejection fractions and tachycardia continued to be my patients until I left Philadelphia 2 years ago. So lived more than 40 years with their disease, so subset. And then, of course, we have groundbreaking new therapies, sacubitril, valsartan, and this is just a little schema of how it worked. And if any of you were there at the ESC meeting where Milton Packer presented this data, and although it doesn't completely show it on this slide, there were about 7 zeros, and Milton Packer read it as 0.00000, trying to impress on everybody how impactful this new therapy was in heart failure. So how are we doing? I think this is a really nice paper published a couple years ago that looks at 30 years of evidence. It was kind of my life story in one, and of course it's all about me and not about the heart failure patient, but looking at just how well we've done in starting with just the improvement in mortality with ACE inhibitor all the way up to adding an ARNI, a beta blocker, and an MRA, a truly remarkable, unprecedented change in mortality or change in survival for the patient with heart failure and reduced ejection fraction. So I love this slide because it really just shows the clinical trials all together depicted in what it meant for individual patients. So the problem is, here's another publication that looks at the age-adjusted heart failure-related cardiovascular disease mortality rate in the United States. And in some groups, young Black men, the mortality is going up. And in fact, for all groups, the mortality rate is not going down. And even older adults, where we were beginning to see some decreases, there's a very ominous slight increase. Not good news. And if you look at, for instance, this was a publication coming out of the European Society of Cardiology. They looked at their heart failure guidelines published in 2009, 12, and 16. And here's the uptake in evidence-based guidelines. Nothing. No impact whatsoever. So I really have had sort of a crisis of faith in the process of guidelines, and I've had, because of my new job, I've been at the American Heart Association now a full year as staff. I've really had to look at several aspects, sort of the foundation of our guidelines. And so I'm going to go through with you fairly quickly how we decide at the AHA to fund research, including return on investment of research funding. I mean, what are we getting for the money we're spending? How we disseminate research results, developing clinical practice guidelines, and is there a way to do that better? And then the implementation of guidelines. So this is part of the paid political announcement about the AHA, so just hold tight for a minute. So many of you know, in fact, often if in this audience, if you say how many people got started with an AHA grant, and if you hold up your hand, many people did. We funded $160 million of new research and actively have about $500 million of active grants this year at the AHA, and we're the largest not-for-profit funder. As you can see, besides the government, as you can see, most of that is traditional basic science investigator-led research, some population and some clinical investigation, and depending on what your viewpoint is and what your skill is and what your interest is, you may disagree or agree with that. And again, we get lots of clamoring that we should be funding early investigators, and then a lot of people say, oh, you should be funding mid-level and then senior investigators, and we basically can't do much right, depending on who you talk to, even though we're spending $500 million a year. So as a result, it's really part of my job to think long and hard about, do we need to really re-examine our research portfolio, and what are we getting for the money we're spending? And this is in the setting of lots of issues and widely read articles talking about that our traditional funding models aren't necessarily great. So this was in the New York Times, a required journal to read, about why the medical research grant system could be costing us great ideas. This was a very prominent article and was taken up by a lot of news outlets, and it said, it's harder to find in general, which everybody knows, but the current approach favors low-risk research and proposals by older white men scientists. And then this got the basic science community very excited. That was in Nature, that said large teams develop, meaning sort of just incrementally increase science, and small teams disrupt science and technology, and showed that by looking at articles, patents, and software. This was really the buzz in basically the research community. And at the AHA, we were very interested because one of our newest funding models in the last few years has been strategically focused research networks, which really was counter to investigator-initiated research. It was to say, what do we as an organization want progress on? And you can see, you may not be able to read it, it's a little bit difficult, but there has been the ongoing viewer networks, which have neurologic science, hypertension, disparities, women's cardiovascular disease, obesity, cardiometabolic health. So, and this is bringing several centers together, 3 or 4 around a topic. And so there were lots of people, and we thought it was an ideal environment for training the next generation of scientists. We thought it was a great way to move science forward to directly accelerate the fulfillment of our mission. So when people start to say this isn't really a good way to discover new science and disrupt science or technology, we paid attention. Second of all, we tend to think pretty small. When we talk about the range of technologies to bring new therapies to our heart failure patients, or new clinical trials or guidelines, we, in general, we think about it in these boxes as either a drug or a device or a biologic or a biomarker assay and an imaging procedure. I'm looking at a surgeon, so I said, well, maybe a surgical procedure. But so I think that this is how we tend to think because we're practical and we know what's been done before us. But Callum McRae, who's up at the Brigham, who was the beneficiary of our grant called One Brave Idea, where he got $75 million. 25 came from Verily, 25 came from AstraZeneca, and 25 came from the American Heart Association. And this was a way of disrupting how we do science. It was a charge from the people at Google that said, you know, you just can't get anywhere if somebody spends half their time writing a new grant. So let's give him all the money and charge him with finding a meaningful answer to coronary artery disease. And what he has done, which most of the time when he talks, it's really hard to understand him because he's gone into the next zone of research. But he has this slide, which I immediately stole, which shows here's what we use to phenotype our patients. In general, it's technology that hasn't changed for 50 years. I mean, the EKG has not changed in 50 years. Echo, the few new buzzes, little things. Cardiac catheterization. So, and yet, what we know is that if you look at an individual, you can describe them in billions of ways, from their exposure to the environment, to their genomic or transcriptomic or proteomic ways, their connectomes, how those things connect, and the physiome. So these are all ways that we could better describe people, and yet time and time and time and time again, when we're doing clinical trials or doing research, we go back to what we've known for 50 years. And we have to figure out a way around that. And finally, when we talk about where should we invest our money, what's important, I think this series of slides just ends up, every time I see it, is so powerful. So the University of Washington has an Institute for Health Metrics and Evaluation, and they developed this thing called the Global Burden of Disease. And they just take data from all over the world and can compile a lot of statistics about what it is that's hurting and helping people in this country and all over the world. So they go to many countries and give them their data and present it in ways to help inform policy. So if you ever are bored and you really want to look at neat slides, go on the Global Burden of Disease website, and there's just every kind of way you can to look at data. So I'm just going to show you a quick series. So this is the United States, all ages, both sexes, the deaths in 2017. And they're, to be fair, their picture is even bigger than I could fit on the slide. But what you can see, as we all know, is that ischemic heart disease and stroke are the number 1 and number 3 or 4 killer, depending on what you look at. Here's cancer, COPD, Alzheimer's is trying to catch up. So that's everything. Then you can look and say, let's look at the deaths that are attributable to all risk factors that we know. And not surprisingly, you see that the big ones change. Alzheimer's changes somewhat because we don't know all the risk factors for Alzheimer's. But heart disease, stroke, and lung cancer really don't change. We know the risk factors for these. Now let's just look at what happens if you just look at metabolic risk factors. Glucose, LDL cholesterol, blood pressure, obesity, and kidney function. Look what happens. So one could argue that if we're really going to make an impact on these big killers, we should concentrate on metabolic factors. Why would we fund research that has something to do with anything other than those? And there's voices that say that. Let's just look at what happens if you say, here's the deaths attributable to air pollution. So COPD is still in there. So does that mean we shouldn't care about air pollution? In fact, the AHA has decided to finally weigh in on air pollution, which is a huge political quagmire. But one could say, why? If we really want to change outcomes, is that important to do? So I think it's a powerful set of slides. Then, as we try to decide, well, how are we doing? How well did we do in funding? What has it gotten us? This has been something that the NIH has been struggling with a long time. This was a publication several years ago by Mark Lauer and the NHLBI, trying to look at, if I asked you, what's the best way of saying how impactful science is, you might say citations. And yet, here is the highly cited paper of each of their grants, and there's just really no correlation whatsoever with what is a really good paper and how well it's cited versus it's not well cited. And they concluded in this paper, and have continued to conclude, that there needs to be a lot more research and consideration into innovative approaches for evaluating research, that we just don't even know how well. So, I showed you the statistics about heart failure. Does that mean everything we've done has been a poor investment? So, when I left Penn, I went to Fondation Leduc, or Leduc Foundation, for a year and a half. This is a French-based organization that has a boatload of money that they fund an international model called a Network of Excellence. And they have to bring together well-established investigators, usually somewhere between 6 and 10. There has to be a North American coordinator, or PI, and a European, and they come together around either cardiovascular or neurovascular type. And so my job as their first chief science officer was to say, how well have they spent their money in the first 10 years? And I'm just going to take you through it. I mean, if you talk to somebody in the basic cardiovascular community and talk about a Fondation Leduc grant, it's highly meritorious, very competitive. And when I would meet the scientists that had been in Leduc grants, they said it was the single best experience I've had in my life. Outside, their marriage and things like that. So, So this was just, they were, for the first 10 years, there were 39 networks that represented 19 countries. There were 4 neurovascular, 4 myocyte. The president of Leduc, David Tancredi, said 14 of them they thought were pretty risky when they funded them. A lot of scientists, underrepresented women as usual. And here's how many investigators were per network. So going back to big versus small. In general, it was somewhere between 5 and 10. And you could look at, a relative citation index, which I did. And it turns out the one with the highest RCR was Peter Libby's paper on inflammation and atherosclerosis. It was a review. The next one was remote ischemic conditioning, which actually has gone all the way to a clinical trial. The antiphospholipid antibodies and risk of myocardial infarction was next. And then mitral valve disease, which was a whole network around morphology of mitral valve disease. So, that tells you something, that at least people are reading these papers. You could look at clinical trials. Here is a clinical trial that was, again, followed by about anti-inflammatory therapy. And Ridker and Libby were in one of the earliest Leduc grants that was about atherothrombosis research. So if your goal is to bring treatments to patients faster, and that's why you do research, this one network seems to have been a home run. The drug has not been approved yet, but nevertheless, it was a home run. And here's publication productivity. I think you could argue that it's across the spectrum. Here's clinical trials, and the older trials, naturally, because most of these are basic scientists, the older networks have more clinical trials associated with the later ones. So I concluded at the end that it's really hard to decide how well your investment dollars are returning. I could point to one therapy out of the 10 years. Again, if you ask the basic scientists who mostly populated, they thought everything was just super and it was great. But if Jean Leduc came back from the dead and said, how's everything going? He might be a little upset with those numbers. So the other thing that we have a lot of trouble with, both in our guidelines and in our funding, is what kind of trials to fund. So the traditional randomized clinical trial, which, by the way, we only consider as the highest form of evidence for guidelines, is the randomized clinical trial. And most of this is done in patients that either have risk factors or clinical disease. But in fact, what we'd really like to know is somebody in ideal health, you'd like to randomize them and find out how they do. And so this is the very heart of the issue that was in the New York Times yesterday about red meat and what I don't know if any of you saw it, but it basically, there's a paper in the Annals, several papers that said the analysis of the individual benefit of eating less red meat was not good. And in what many people think was really sort of an irresponsible way, they just said, there's just no good data for you to restrict your red meat. And that's because in order to do a randomized clinical trial, which is what people think are good trials, you'd have to take a whole bunch of people, like I'd say, okay, all of you over there, no more red meat from now on, and you over there, you get to eat red meat as much as you want, and then we'll see you again in 25 years. Well, obviously, that's not easy to do. So the answer is to do an epidemiologic observation study, which is, of course, what the data around red meat and around sodium and around so many other things are done, but they're not considered the gold standard in our community. And what we really want to get to is randomization in a free living cohort, meaning all of you just go on with your lives, and through electronic medical record, we're going to randomize you, but otherwise, just keep doing what you're doing. And that's the goal, and this has been happening. There are a couple of trials that are out there that are using the EMR to find patients and randomize them, and they've perfected this beautifully in Sweden, where the entire country says, just consider me enrolled in a trial. And they've got data on everybody. They have unique identifiers on everybody, and they're light years ahead of what we're doing because they've embraced this idea of a different kind of trial is needed. Okay, so that's all the issues around funding research about and not only is this happening in the AHA, it's happening everywhere. Big foundations are evaluating it. The NIH is ongoing, so those of you who are in clinical trials, the NIH has cut back, the NHLBI has cut back major league on clinical trials. So if we're waiting for a clinical trial to answer a clinical question, don't hold your breath because it's going to be a long time in funding. How about disseminating? So we all have 1 million journals that come to us either electronically or in our mailbox. When I moved to Hingham, Massachusetts, which is a little town south of Boston, I have a male woman who said, "Oh, I wanted to meet you. You got really heavy mail," because of course I got lots and lots of journals that came every day. And so notice I've managed to talk about 14 slides without talking about precision medicine, but I'm going to talk about it for 1 minute. So the idea behind precision medicine, as I'm sure you've heard 2,000 times, is that you describe somebody. Here's this deep phenotyping again. You describe them through their health system data, their participation in trials, their motivations and behaviors, their Fitbit, their microbiome, their environmental exposure, and other omic data. So then you know this person, and then somehow they go into a trial, and you take that data, you recruit them, you take the data, you describe the patient, you curate, analyze it, report it, and then it's supposed to feed back. Notice there's no arrows here. It looks like just this ongoing circle. It's supposed to feed back into a learning system. So where does a journal article fit in there? So just randomly, I found this article that sort of crosses EP and heart failure about a development and validation of a new risk prediction score for life-threatening ventricular tachyarrhythmias and laminopathies. Really important subject. Really nice looking data. And the question is, so it stands in a journal, and then what happens? Where does it fit in this system? How, we may get data from clinical trials, but how do we get data that's published in a journal if you didn't happen to read the journal that day, or you got distracted by the 14 other journals you subscribe to? How did you learn about that? And where did it get into the system? And how did we test out their system? I don't see a pathway for that. And that's a problem. Now, I don't know if you've heard about the Fda Sentinel Initiative. So the FDA, I just heard about this one day. I was at the Heart Failure Collaboratory, which is a multi-stakeholder effort around heart failure infrastructure in this country. And the FDA are there, and this guy in a uniform got up and started to talk about Fda Sentinel. And this is an article that was in the New England Journal, and I neglected to cite it. But so they went out, the FDA, and partnered with about 200 health system leaders and pharmacoepidemiologists and clinicians and data scientists and patient representatives. And they're not taking any data. They ask questions, and then they ask for this back. And so they're learning about whatever it is they're asking. I don't know where that's going in the precision medicine system. Sounds like it's pretty closed loop to me. So of course, everybody says, oh, well, this is all going to be taken care of by machine learning. And that's the other slide that I managed not to show to you for about 15 slides. And what we do know is that there's a whole bunch of new topics that people throw around, like genomic editing and computational engineering and digital consumerism and cognitive computing, all these things that is supposed to make precision medicine better. So let's just talk briefly about machine learning. So this was another article that was in the, I started to say New England Journal, it was the New York Times. And it shows a room full of people in India. And they are circling pictures of colonoscopies and circling what they think is a malignant lesion. And then they're feeding that into the machine so that a machine can do machine learning on who's got malignant lesions or not. So is that how you thought artificial intelligence was going to work? How machine learning, that actually a human was going to put the data in and then the machine was going to learn from that? That's not what I thought. So that artificial intelligence is as good as the data humans use to create the intelligence. So the EP world, they think that eventually, not they, we all hope that one day that you're just going to show a heat map or whatever it is that is cool now. And that artificial intelligence will read this and know exactly where to ablate. But the only way that's going to happen is if the EP docs tell the machine this is where to ablate. So that's only as good as the EP docs are at knowing that. But here is the real problem around machine learning or anything else. So this is one of my favorite papers that was in the New England Journal. And they looked at what had been described as the pathogenic variants in HCM. And they said, we got it. Here they are. These are the variants. And if you got it, you're in big trouble. But then they took, and it turned out that most of those people were white. So then they took blacks and they tested them for variants, and I thought, holy cow, those people all are going to get HCM. Well, it turns out those were benign variants. And they misclassified those variants as pathogenic only because they only tested it in white people. So if we're going to do machine learning, we better make sure that the information we're handing to the machine is a diverse group of people. Because if we don't, we're going to make major errors. Or, by the way, the machine will make errors. Nobody will say it's our fault for not looking at the patient population. So then let's talk about developing clinical practice guidelines. Do we need them? I started out by saying, you know, do we really need them? So this was a presidential advisory that was published again this year in Circulation. And it talked about the large missed opportunities at every step in prevention and treatment of cardiovascular disease. We make no risk factor modification, 80%. We don't get people engaged. If they're not engaged, they're not going to follow the program. We fail to diagnose heart attacks. And we don't even recognize hypertension. And 30% of people walking around in this country don't know that they have hyperlipidemia. We fail to use first-line treatments in about 50% of people. And about half of people with atrial fibrillation are not on therapeutic half. And failure to use advanced treatments and failure to provide. So we don't even deliver hospice when it's appropriate. So there's lots of opportunities. So you'd say surely guidelines should help that. So the Institute of Medicine says this is what a guideline should be. It should be a recommendation after a systematic review of evidence, and you should talk about alternative care. So what are the options if you choose not to go through the therapy that's been outlined? But here's the problem. So in heart failure, in my field, in contemporary heart failure trials, older patients and women are consistently underrepresented, and race, ethnicity data are reported in less than half trials. So if you have a black woman in your office, those people weren't put in. I don't even know how many people were put in some of the trials because it's not even reported. And the questions that we as clinicians have to answer, there's no incentive for industry to answer them. So the classic one is cardiac resynchronization therapy. You know, there's lots of questions. There's no doubt that some people are super responders, some people are negative responders, but we've not done a lot of trials to answer which is which and how do you identify them. So how do you write a guideline? I spared you the complex algorithm about how to decide which patient to put a CRT in. And then whole segments of our population are just receiving different care even within a trial. So this was the landmark heart failure trial, Paradigm HF, that looked at ARNI. And it turns out that women with HFrEF live longer than men. Their additional years of life are poor quality, more psychological and physical disability, and they received suboptimal care. Now, these are the clinicians who are driving our guidelines, and they gave women much less anticoagulation, much less devices, including CRT, more digitalis, and more calcium channel blockers. And then we write guidelines, and they're not very helpful. So I'm ashamed to show you that what we wrote in 2001. We said diuretics in patients who have evidence of fluid retention, class 1, level of evidence A. ACE inhibitors, and all in patients unless contraindicated. So maybe you'd think so. That's pretty good. But now look how we've changed it. Diuretics should be used for relief of symptoms due to volume overload in patients with HFpEF. Or the use of ACE inhibitors is beneficial for patients with prior or current symptoms of chronic HFrEF to reduce morbidity and mortality. but I just went to a guideline writing committee meeting on Saturday, and the why are you doing this, got eliminated in 50% of the recommendations. Or I shouldn't say eliminated, they didn't put it in. So we tell people what to do based on the clinical trials, but we don't say why. And then we're not helping people decide on value, which is what patients want to know. What's the value of spending extra money on this therapy? And so this was a review that said less than half of the studies identified and reported significant quality gains between intervention groups. So we're not even looking at that in our clinical trials, so how can we report that in our guidelines? The cholesterol guidelines that were just published had a value section on the PCSK9 inhibitors. Now, whether it's related or not, as a result, the cost of those drugs have decreased twice because the value for only a small set of patients was not good. And that was just pure data. Now, that's impactful. And we don't do it very often. And then patient-reported outcomes. This is, again, another review a couple of years ago that said, there's lots of compelling reasons, but we don't do it. We don't ask what patients think. We just count bodies and hospitalizations. But here's one of the best studies that I just think is amazing. So they went, this is a group in Europe, they went to a whole bunch of clinicians and they said, so what is the expected death rate of a procedure or an intervention before so that you feel like you have to give them an informed consent? In other words, if we give you general anesthesia, you have to give them an informed consent. We all do that. We do it in front of caths and before cardioversions and everything. So here is the risk of death from general anesthesia, 1 in 150,000. But none of us would ever proceed without a consent form. So here is the risk of death of just not taking a beta blocker for a year. It's 1 in 21. Do we give consent forms to patients that say, yeah, I'm not taking that? No, I mean, who would know what the numbers are? So maybe our guidelines have to say, and if your patient won't do this, here's their risk of death. You might want to think about a consent form. I think this is a fascinating way of looking at what are the consequences. I'm asking you to take this drug. It's going to cost more money, but here's the value of it, and here's the consequences, your risk of death if you don't take it. And there's really compelling data for ARNI, for example, or for MRAs, which are even cheaper. And then finally, the problem of guidelines is that it has a huge impact. So this is a paper just looking at the impact of the new hypertension guidelines, the new American guidelines, and 4.2 million Americans would take more drugs. And is that okay? Is that going to be okay? I mean, that's a heavy responsibility. So finally, I'll finish with implementation of guidelines. I've already told you that mortality is not going the right direction. Here's where we thought it was going to be, and here's what's happening. And I've showed you that already, and there was a whole lot of data from a variety of government sources that said our life expectancy is going down, our age-adjusted death rate is increasing, and the 10 leading causes of death in 2017 remain the same. And there they are: heart disease, cancer, injuries, and stroke. And again, our guidelines really haven't done much. This is just a guideline, again, coming from this country, looking at the impact of the guidelines saying, use ARNI. And we coordinated it with the Europeans. We put representatives on both guidelines. We came all out in the same week, and all the journals, everything. And this was a tiny bump. And then the CHAMP-HF registry that carefully looked at a number of hospitals, If you can see a difference between those two slides, between baseline and 12 months, I can't. No impact. So what are we going to do to get clinicians to do a better job? This was a really interesting study that said, here's the ways. We can remind patients. We can give them education. We can audit and feedback. We can pay them for performance. And what they found out is the only strategies that really work are audit and feedback. The reminders, which we all have on our EMRs, which drive us crazy, which we just click through because we can't stand it, are ineffective. There's a whole industry behind trying to get us to do the right thing, and yet there's no evidence that it works. So, of course, the American Heart Association has a Get With the Guideline program, and in heart failure, we've shown that it works in teaching hospitals and non-teaching hospitals. It is truly a tide that raises all boats. A quality improvement program can eliminate disparities so that when you really focus on delivering the best care for everyone, suddenly you see the disparities of care going away. And I won't bore you with all that. And I'll just, this is our suite of Get With the Guidelines, and just to give you an example of the goals of AF management are pretty simple. You know, anticoagulation rate control and rhythm control. And here is a study that was published last year that looked at discharge, 95% of patients were anticoagulated. This is the highest by far ever reported level of anticoagulation in atrial fibrillation patients. It sounds good, but what if your mother was the one in the 5% that didn't get it? And in this, we're not doing so well. This is just our international programs, and China has, you know, they have a much higher incidence of stroke even than we do in this country. And they started in 2015 a program that's based on our Get With the Guidelines. Of course, they can't call it that. And they decided they were going to find 150 hospitals. They were going to recruit across the country, and 10 to 20 inpatients with AF are enrolled. And of course, in China, like, you quickly get to 28, 35,000, and they're reporting on the results. And are they great? But no. But they're no worse than what you see in that CHAMP HF. So what does it take to have accountability? We have to take accountability for this. It means you have to have strong evidence that medical care influences the outcome. Well, that's what our clinical trials show us. Outcome is measured with great precision. That risk adjustment includes accurate measures of factors most strongly associated. And using the measure must have little chance of leading to adverse unintended consequences. Of course, that's, I don't have to tell you, here at Yale is one of the big debate issues around our current readmission policy in heart failure. But more importantly, we need competent staff, including physicians. Physicians have notoriously said, yeah, let the nurses do that. We need champions with clear roles and responsibilities. We have to have evidence-based procedures and practices, which may be the role of guidelines. A quality improvement approach that monitors adherence, and a review of performance, making adjustments. You have to get feedback. The great hope for our electronic medical records was that it would improve care. But aside from those little prompts that we click through, we're not getting, most hospitals are not getting periodic reminders like, by the way, you've got 30 patients who have AF that we don't see anticoagulation on. So what I think we have to do in the future, if guidelines are going to mean anything, is, first of all, we have to continue to do efficacy studies, but deep phenotyping the people a little bit more so that at the end of the day, at the end of the trial, multi-million-dollar trial, we know better who got treated and who responded. We have to do effectiveness studies that really look at the role of a drug in a population, like a real world. And more there's talk about doing a hybrid design. there is so little work on implementation research. How do we get clinicians to do the right thing? And that's going to be improving our processes and outcomes, and we have to do it across a continuum. So as hard as it might be, we're going to have to figure out ways to study people that are at ideal health. So for those of you who are Game of Thrones, I think this is a discouraging topic, but chaos isn't a pit, chaos is a ladder. Littlefinger, of course, died, in case you... But it is an opportunity, and it's an opportunity for the young people that are coming into this field to learn from our successes, but learn from our mistakes too, and quickly change how we do business in the future. So thank you very much.